You guys have a lab today or something? Oh, something. All right. That'll be good. Well, today we're talking about endocrine disease. Talk a lot about the thyroid. So we'll look at solitary nodules, tumors, and we'll talk about some benign conditions and then other endocrine disorders that we might see that require surgery, like, adrenal masses and pheochromocytoma, Cushing's syndrome. It's important to look at the anatomy here first, though. So you got your thyroid, and it has two lobes connected by a central isthmus. What's important to note, so it has two different arteries that supply it, but as you can see, it's a very vascular area, which is going to be important when we look at doing surgery on this, and some of the complications we might have is obviously with that increased vascularity. We can have damage to some of those vessels when we're doing surgery. We'll talk about it in the complications. But what's nice about the thyroid is, so we have an easy test we can measure with it called our TSH. So our pituitary responds to the TSH. Basically, we have a negative feedback loop here. So the TSH is the major stimulus for the thyroid gland to produce T3 and T4. It provides a negative feedback loop to the hypothalamus, which releases our thyrotropin releasing hormone, which tells the pituitary to release TSH. And with that negative feedback loop, we can have some problems, and we can easily measure that with a TSH and typically a free T4. We can also measure T3, but typically we get a free T4 with it as well in the blood, which we'll talk about. All right, so what's our job? We got to figure out, if the nodule is benign or malignant, and we also have to look at symptoms it might cause too. Since it is a very vascular area there and it's right next to the trachea on either side, we can have compressive effects with those nodules as well. So our differential for this one is going to be like a benign goiter, intrathyroidal cysts, thyroiditis, benign malignant tumors, and rarely metastatic tumors to that area. So history, it's important to note, obviously, what they're coming in complaining of, whether it's swelling, growth, and then if they're having any sort of symptoms related to an abnormal thyroid function. Important considerations are age. So we have a kind of a bimodal distribution here with thyroid malignancies. So typically in younger, under 20 years old, and elderly over 60 is when we tend to see it more frequently. Men have a higher chance of malignancy when they have it, but women, it's more common or a higher incidence with thyroid nodules in women. But we need to look at also, certain geographic areas can affect this. Family history is very important. And then any radiation to the neck, like they used to do external beam radiation for certain treatments in kids, which we don't do anymore, but they used to be a thing like in the 40s and 60s, and we'll talk about it here. So we used to use it for like tonsillitis, acne, thyroid tumors. We would shoot beam radiation to that area to help alleviate those symptoms or those conditions, and it turns out it was, it caused more thyroid cancer later in life. We also still use XRT, so typically we use it for breast cancer, we use it for Hodgkin's lymphoma, so we can have an increased incidence of papillary thyroid carcinoma with that XRT treatment. And then we also have to look at family history as well, so medullary carcinoma, we see it with the men 2A and 2B syndromes, which we'll talk about here shortly. And those are just multiple endocrine neoplasia syndromes that you can see a lot of other conditions with too. And on the right, we have some images there that, we have a chest x-ray with a widening of the mediastinum. Typically from, this one is from a classic Hodgkin's lymphoma. So you can see that lymphadenopathy there. All right, so how do we examine the thyroid? You guys remember? You still practicing this on each other? Probably not. So you want to stand behind the patient. You want to do like universal, like choking someone out kind of position, and you're going to palpate the thyroid. So you want to have the patient swallow or raise the thyroid, and then you want to feel it in the adjacent lymph nodes for any nodules or irregularities in there. So typically, we like to categorize them on palpation of like whether it's pea-sized, whether it's grape-sized, And then we want to determine whether it's firm and mobile, whether it's hard and fixed, because those can be more concerning for malignancy. So hard and fixed typically we associate with malignancy, and then firm and mobile nodules are usually benign and just cysts. So we also need to evaluate for any obstructive symptoms that they might have. So if they have any stridor, tracheal deviation, JVD. As you can see on the imaging there, we do have some tracheal deviation from a thyroid nodule. But it's important to evaluate this during our exam. All right, so what do? So once we identify that we have some sort of abnormality, whether that's from symptoms, whether that's from a nodule, the first thing we need to do is get their TSH level. Typically when we order it, most places will have, the order you place is like a TSH and they reflex the T4 with it. So we're looking if the TSH is low, and we have a high T4, then we have hyperthyroidism or a functioning nodule. We also need to evaluate whether we can check some other antibodies too, so we can look, evaluating for Graves' disease and other conditions that can be causing this. So we'll also get some thyroid antibodies if it's abnormal. And then we have a very complicated algorithm here in a second we're going to go over, but it'll make sense at the end, hopefully. But after that, our first test is going to be ultrasound. So that just helps define the nodule. So whether it's solitary, whether it's multinodular, it'll help us whether it's cystic versus solid. As you can see in the picture there, we have needle aspiration of a cyst. And a lot of times we can do it ultrasound guided just because there's so many other structures in that area that we can risk damaging. We wanted to usually do it under ultrasound guidance. And we'll talk about fine needle aspiration and other techniques we're going to use here to help diagnose these. All right, so we found a nodule. We've run their TSHs low, and their T4 and T3 are high, so we have hyperthyroidism. So our next step is going to be, after the ultrasound, is determining whether this is a hot versus a cold nodule. So we do our radioiodine scanning in these patients. So typically a hot nodule with hyperthyroidism is rarely malignant, whereas a cold nodule is more concerning for cancer. So this is kind of how we base our treatment algorithms on what's happening here. So if we have that hyperthyroidism, we have the low TSH and increased uptake, that's less suspicious for malignancy versus like our low TSH and a cold nodule or decreased uptake, we worry about like a subacute thyroiditis, we worry about malignancy in those ones, and we'll talk about the different malignancies. But it's also important that we look at family history too. So for medullary thyroid carcinoma, so our MEN2 syndromes, which we'll cover, but they have a higher tendency for like an adrenaloma or pheochromocytoma. And then we also have like hyperparathyroidism, which is associated with some of them as well, which we'll talk about here. All right, so what do we do for these solitary nodules? So we don't remove all of them. Obviously, we want to decide whether we think it's, whether we suspect it's malignant versus benign. And then we have to look at any sort of compressive symptoms or other symptoms they may have from that nodule. And then typically, if we suspect or it's proven cancer on our fine needle aspiration, indication for surgery or malignancy, follicular neoplasms is hard to differentiate whether it's adenoma versus a carcinoma. So a lot of times we'll do a partial thyroidectomy for those and send that specimen, which we have a slide covering that later. There's any atypical cells, and then hormonally active nodules, cystic nodules that recur after 2 aspirations. And we'll cover this complicated chart here in a moment. But obviously, if it's functionally malignant, like they're toxic, they're having like thyrotoxicosis or anything like that, we're obviously want to remove that, or it's an indication for surgery, and then cosmesis reasons as well. So some of them can be pretty large. We'll show you some pictures here, and so obviously cosmetic reasons, they're probably going to want that removed. And then here's this crazy chart. All right. So on the left side here, we've got, this is going to be our abnormal thyroid function studies. So Our focus is, and we're going to go over it in the slides too. I don't like this chart, but we're going to go over it. I guess, does anybody like this chart? No. Yeah, right? It's hard to learn. We're going to cover it all, but really we're focusing over here on the euthyroid patients. So they have normal TSH, and they don't have any sort of signs of hyperthyroidism or hypothyroidism. So we're going to order that ultrasound. And then if it's cystic, we're going to aspirate it and drain all the fluids, send it for sampling. We'll do that twice. So we follow them up at 6 weeks. If it recurs, then we drain it again. And if it has a recurrence after that, then we look at doing a thyroidectomy, a partial thyroidectomy for those ones. Now, if they have multiple nodules, typically if they're having compressive symptoms, or it's over 4 centimeters, then we look at removing it and doing surgery. If it's a solitary nodule, then we do the fine needle aspiration. And if we have any signs of malignancy, we go to that bottom right of the chart where we look at procedures that we can do. So typically, if we get a good sample, we'll look at removal if it's compatible with any sort of carcinoma. And we'll go over these in the following slides. I know this is complicated on here, so hopefully it makes sense at the end. All right. So you got 30-year-old female. She's got a firm, palpable nodule on the left side of her thyroid. It's 2 centimeters. What's the most appropriate next step for that? For this patient? It's easy, right? TSH. Good. So that's our first step. What do we do after the TSH if it's yeah, we want to ultrasound that. What about if they're hyperthyroid? What are we thinking for that one? Yeah, we want to figure out whether it's a hot versus a cold nodule at that point. Good. And then we look at whether we need to do a fine needle biopsy on them. All right, so benign tumors of the thyroid. So we have our follicular adenoma. The issue with this is it's difficult to distinguish between carcinoma. So this, a lot of times, we'll remove this for suspicion of malignancy, and we'll typically remove only one. We'll do a partial thyroidectomy and then send it for sampling, which we'll cover in the following slides. And then toxic adenoma is when we have hyperfunctioning thyroid tissue. This is going to be our abnormal TSH studies. Typically, we see it more commonly in females when they have this toxic adenoma. They'll have a hot nodule on the thyroid scan. We'll give the radioactive iodine for treatment. If it's less than 4 centimeters, then if it's over 4 centimeters, we're more concerned with like compressive symptoms or malignancy, so we'll remove it at that point. All right, so malignant thyroid nodules. So these are the ones that, like I said, they have that bimodal distribution, younger than 20 and then over 60 in the elderly. More likely malignant in a male patient with a solitary nodule, elderly, and then anybody who's received XRT. I don't know that I've ever seen a patient that's gotten XRT, but maybe I'll start asking these old patients if they've ever had them when I see them. All right, so we have our papillary and follicular, the most common carcinomas that we have. So papillary is usually multifocal. It can cause lymphatic spread. It accounts for most of these cancers, about 85%. And then we have that are more commonly solitary nodules, are the follicular carcinomas. And these are the ones that are associated with those multiple endocrine neoplasia syndromes, which we're going to cover here in a moment. But the follicular has a higher propensity to metastasize to bone. So it's always something we need to consider if we diagnose them with follicular thyroid carcinoma. And then there's also medullary and anaplastic, which are less common and we're not going to cover. All right, so like we said, papillary thyroid carcinoma is the most common. We see it in it was important that we talk about like geographical distribution. So we see it with like iodine deficiency and regions that don't have iodine added to their salt. And we also see it in children and then the post-XRT patients. This is usually multifocal. And then it does have early spread to the other lobe and regional lymph nodes. However, it does have a great prognosis, so these patients do go on once we perform the thyroidectomy to live a good life. Follicular neoplasms, these are the ones typically associated with our multiple endocrine neoplasia syndromes. And we typically see these later in life, so these are usually the elderly patients. And this one requires surgery, whether it's a partial versus a complete thyroidectomy. Obviously, if we remove the whole thing, we run into other problems. They then have to take exogenous, thyroid hormones for the rest of their life. So it is something that we're going to have to manage. Now we have to worry about, obviously, parathyroid hormone usually is there as well. Or our parathyroid gland gets removed as well. So when we evaluate these, we'll typically send to the pathologist, and they'll decide whether it's adenoma versus a carcinoma, and then we'll base our treatment on that, on whether we need to do a complete thyroidectomy. Alright, so medullary thyroid carcinoma, this is typically going to be a multifocal, multilobular, it is metastatic. There are some tests we can run for this, looking for our MEN2 syndrome. We could test for the RET proto-oncogene. And then we also have to consider whether it's producing calcitonin. We'll talk about that later when we're looking at some of these other syndromes and other labs we have to order for those. But the treatment for this is a total thyroidectomy. All right, here's our multiple endocrine neoplasia syndrome. So as you can see on the right side there, which is what we're mainly going to talk about at the first part of this lecture, so we have our medullary thyroid carcinoma in 100% of those patients. So some of them will have a pheochromocytoma, and they may have hyperparathyroidism in MEN2A. MEN2B is typically the most aggressive of these and the most concerning. And these are the ones they'll have, they may have neurofibromatosis, they can have a marfanoid appearance. So if we have differentiated thyroid carcinoma, typically we're going to do operative removal, partial or total thyroidectomy. And then we may have to do some adjuvant therapy for thyroid cancers, obviously they're going to need that thyroxine to replace the hormone, suppress metastases. We'll do the radioactive iodine after thyroidectomy to reduce recurrence. It increases survival. And then, we don't use XRT as often anymore for this condition, but that used to be a mainstay of our therapy, which we don't do anymore. And then we have to decide whether they need chemotherapy or not. This is usually in conjunction with our with the cancer doctor. So typically we're not managing it at this point. All right, so you got a patient, gradually enlarging throat lump, back pain. Patient is subsequently found to have lesions of the bone, likely metastasis related to thyroid malignancy found in work. Which one is the most common? What did we say for this one? Earlier. Follicular is going to most commonly metastasize of the bone. Good. All right, and so now we'll look at some of our benign conditions, and this one's going to be the most common. It's a thyroglossal duct cyst. So it's a remnant of the tract of the thyroid gland that descend into the neck. So they account for about 70% of abnormalities of the neck. And the thyroglossal duct cyst has a tendency for infection, is what we see this frequently with. As you can see in that bottom picture, they can get an abscess and they have a high incidence of recurrent infection. So typically, we're going to remove these. We'll do an ultrasound first. We'll make sure the TSH and their thyroid function is appropriate. And then we'll treat with antibiotics and then elective surgery on these ones. Typically for most abscesses, we like to drain them, but this one we want to avoid doing an IND just because of the high recurrence rate of infection. We also have, which we're not covering here, but we also have branchial cleft cysts, which are the other common cyst or common condition we'll see in the neck as well, and that's going to be more of a lateral neck mass, and typically smooth and painless. But that'll be another common one we see, but it's not midline, so it's usually easy to differentiate whether it's a branchial cleft cyst versus the thyroglossal duct cyst. All right, goiter. That doesn't look good. So, like I said, depending on the area, this is like region specific as well, so if we don't have iodine in their diet, that's why we have iodine in the salt in the United States. But the thyroid is sensitive to iodine. So if we don't have enough iodine in our diet, the thyroid gets larger, or it enlarges to try to account and basically capture all the iodine in the body. So it enlarges in response to that low iodine. And these patients can have, obviously compressive symptoms. I can't imagine that guy right there. That's pretty large. Never seen anything that bad, but we can also have congenital defects as well, and then we might see that with Hashimoto's. Typically, they respond well to a thyroid hormone administration. We just have to monitor for those compressive symptoms like dyspnea, dysphagia, any sort of venous obstruction. If they have typically diffuse goiter, it'll be symmetrically enlarged on both sides. It'll be smooth. And then obviously we need to do the thyroid function study and a radioiodine uptake study just to determine whether we have a hot versus a cold nodule. Typically in goiter, the thyroid function is usually normal. However, if they have a hyperthyroid state, we may see some radioiodine uptake. All right, so due to location of the thyroid, what we worry about is like mediastinal masses. So the most common clinical presentation is a substernal thyroid, and that's just from enlargement, and then it ends up in the anterior mediastinum on these patients. And then obviously, we're not going to talk about thymoma, but that's obviously the most common neoplasm we see. But this is typically going to, this is something we might see on a chest X-ray. Then we have to decide what's causing this. And like it says, most common is a thymoma, which you'll probably see on some of your chest X-rays. They'll have like leftover thymoma from when they were a child. So what do we do for these? So obviously, any of the compressive symptoms, we do surgery to relieve those symptoms. We want to rule out cancer, like we talked about earlier. And typically, multinodular goiter is usually benign, but because of these compressive symptoms, we need to, be concerned about all of their structures in the area. So we will remove them. And like I said earlier, because of all of the vasculature there, we have a common complication of bleeding. Typically, it doesn't present like with gross blood. That'll be, we'll usually take care of that during the surgery. What we have to worry about post-op is like a wound hematoma. So anything, any sort of abnormality post-op, like any sort of expanding mass hematoma, we need to open that back up and explore the wound because we're concerned that there's some sort of bleeding vessel under there that hasn't been controlled. So if we can, sometimes they can present acutely and we may not have time to get airway control prior to taking them to the operating room. So sometimes we will have to open this up at the bedside to control that bleeding. And then we have a lot of the structures there. So if you have any hoarseness, we could have damaged the recurrent laryngeal nerve. Your vocal cords are in that area. We could have, we also run the risk of removing the parathyroid gland as well. And then with any sort of operation or cut incision in the skin, we got to worry about infection. And then because, like we talked about, some of these are very large and we're taking them out for compressive symptoms, we got to worry about respiratory obstruction as well, so we can cause pneumothorax, edema. And then we need to be concerned after the surgery for any sort of hyper or hypothyroidism. And then obviously poor cosmesis, but that's the patient's problem, right? All right, so hyperthyroidism. So this is what we call thyrotoxicosis, and typically it's associated with Graves' disease most commonly, also Plummer's disease. We have, Graves' disease is an autoimmune disorder. We don't know what causes Plummer's disease, but if left untreated, you can have those, pretty significant symptoms and profound catabolic disturbances. So you're worried about cardiac damage. They'll present with like a hypermetabolic state typically. And what we worry about the most is what we call thyroid storm, and we'll talk about what we do for treating that in a moment. But they can present with heart failure, cachexia, weight loss. All right, so here's the clinical presentation. As you can see, the exophthalmos there on the right, those big eyes sticking out. One of my PAs once told me when I was a medic, she was like, "You need to get your thyroid checked." I was like, "What?" She said, "Your eyes. I think you're hyperthyroid." I was like, "That's messed up." It was normal, thankfully. But they can have nervousness, they'll complain like diaphoresis, heat intolerance, tachycardia, palpitations, fatigue, weight loss. And then typically they'll have, some sort of nodular, multinodular, diffuse goiter. So it's important we do, a good physical exam. Sometimes this may be their presenting symptoms and they haven't, been treated for it yet, but they'll have that like warm, typically moist skin. They'll have thinning of the hair. They can also have vitiligo as well. In Graves' disease, we get that exophthalmos, those big eyes, and they can have pretibial myxedema. With hyperthyroidism, you can have a shortened Achilles reflex time, and hypothyroidism, a prolonged reflex time. I feel like only an orthopedic doctor would be able to know that. If I was checking the Achilles reflex, I'm like, I don't know, maybe that's a little bit increased, maybe it's decreased. But that is another, that is something you might see with this, so that is something to consider. And then thyroid storm are accentuated symptoms. So they'll typically have, hyperpyrexia where, it'll present like a fever, but they'll have the tachycardia, they might have heart failure with it. They'll, a lot of times they'll have delirium and jaundice. So this is an important diagnosis we have to consider in any patient with this type of presentation because it can lead to, poor outcomes if left untreated. So how do we diagnose this? Just, everything is the same here. We need to get a TSH, and then typically we'll get our free T4 with it, and we'll, check to see if they have hyperthyroidism. And a lot of times, most of the time it's very mild. Some of these tests might only be slightly abnormal, so we'll have to do some additional testing if that's the case and they have these symptoms. So we might have to do a T3 suppression test, which basically it suppresses the thyroidal uptake of the radioiodine when we give them exogenous T3. And then we can do a thyrotropin releasing hormone test where serum TSH levels fail to rise in response to the thyrotropin releasing hormone in hyperthyroid patients. So these are other tests if our initial TSH and free T4 are equivocal. We can look at doing these further testing to try to differentiate whether it's thyrotoxicosis or not. And then you might also see like a low serum cholesterol, a lymphocytosis, and then we'll talk about some of the conditions we see, that hypercalcemia, hypercalciuria, and glycosuria here in a moment when we talk about parathyroid, or when we talk about parathyroid. All right, so what do we do for these patients? So typically they'll have to be on some sort of long-term therapy. If they present like in thyroid storm, it's important that we treat them in a specific manner. Typically we have to start with like our rugol iodine solution, then we give a beta blocker just to prevent the peripheral manifestations, and then we need to decrease thyroid production. So we use methimazole most commonly. PTU is more of an acute medication that we might use, but we tend to use it more infrequently just because it has a side effect profile that we don't like. But this basically, methimazole and PTU inhibit the function of the gland, but we don't destroy any tissue. If we've treated that patient and they're euthyroid, then we look at like radioiodine studies or radioiodine treatment for that. We typically want to make sure we've used our thyroid medications first and they become euthyroid. And we can also look at surgery as well and a thyroidectomy, especially if they're having uncontrolled symptoms with our treatment. All right, so all of that, man, it's complicated. You got to know it for the pants. But here's what you guys really do in the clinic. You get a TSH, reflex, free T4, CBC, CMP, ultrasound, and chest X-ray. And then we refer from there. So this is really the primary care responsibility that you guys are going to be, you guys are going to do in practice. However, all those conditions, are important to know, especially for testing purposes, and when we're explaining to our patient what can actually happen to them if any of these are abnormal. So it's good we educate them appropriately, but we can refer them to internal medicine. This is going to be facility dependent. Sometimes, if you have a great endo team, you can refer there, but most of them go to internal medicine for those difficult to control hyperthyroid patients. And then general surgery or ENT for the nodule, large goiters, thyroglossal duct cyst. And it all depends on your facility, which you'll have to check when you're there. Like sometimes ENT takes it. They like to be really complicated at places like BAMC, like 1 day's surgery, 1 day ENT takes it. So it's like, oh man, who do I call today? So it gets kind of complicated sometimes. All right, so parathyroid gland. So parathyroid gland is embedded onto the posterior lobes of the thyroid. So you typically have 4 glands or 4 parathyroid glands, or at least 85% of the population do. Some, about 15% have more than 4. So this can be a tricky dilemma if we are worried about hyperparathyroidism. We have to find all of those parathyroid glands, and we'll talk about some of the studies we can do for that. But most of them are within 1 centimeter at the inferior thyroid artery and recurrent laryngeal nerve. All right, so man, we got another complicated chart here. All right, so parathyroid hormone rises, for any sort of low calcium. Or parathyroid hormones will rise if you have low calcium. And so the other great thing is it's an easy test we can measure. So if we have an increased parathyroid hormone level and hypercalcemia, that's diagnostic for hyperparathyroidism. So it's relatively easy to test for this as well. We're going to talk about some other tests that we have to do on these patients, like the calcitonin, because these actions can oppose the parathyroid hormone, and we'll get into that shortly and how we measure this and manage it. But who gets it? So females more commonly than males. Usually they're asymptomatic, and we just notice it on an electrolyte panel or a BMP or CMP when we're evaluating them. But we'll have an elevated calcium. If you have an elevated calcium in a patient, then you just order a serum PTH. And if that's elevated, that's diagnostic for hyperparathyroidism. So then we have to figure out whether it's a carcinoma versus adenoma versus hyperplasia. So they do have increased risk of cardiovascular effects and malignant disease. And we'll talk about the multiple endocrine neoplasia 1, which is more commonly associated with hyperparathyroidism. All right, you guys remember the hypercalcemia, stones, bones, abdominal groans, psychic moans, fatigue overtones? I mean, a lot of it sounds like, normal symptoms we all have every day. But, so most commonly they'll have the asymptomatic hypercalcemia, and then they may have some sort of renal colic, urolithiasis, hematuria. So these are the most common presentations we're going to see with these patients. So it is something to consider, especially in those chronic urolithiasis patients that you guys have. You're going to need to check these levels. Less commonly, they'll have the weight loss, polydipsia, hypertension, bone pain. And then, where's the, oh, it's on. All right. We'll talk about how, multiple endocrine neoplasia and some of the diagnostic studies we use for primary hyperthyroidism in a moment. But we also have secondary hyperthyroidism. So that's typically a decreased calcium with an elevated PTH. You see that with chronic renal failure, all the different malabsorption syndrome, vitamin D deficiency. Medications can cause this as well. But in this one, secondary hyperparathyroidism, they're not going to have that elevated calcium like you see with primary is the important differentiator. But they will have the elevated PTH. So, what do we need to do for this? It's usually easy. So any of our, basic metabolic panel and comprehensive metabolic panel have our calcium in there. So we need to look at the calcium, which is the most important test for this, and then we need to evaluate their phosphate level. We'll look at alk phos. We want to look at kidney function as well. And, we also want to evaluate, sometimes they can have a hyperchloremic metabolic acidosis, but if our calcium is elevated, we need to get a serum PTH. All right, so plain films are helpful here in patients that have any sort of bone pain. So what we can see is like a subperiosteal bone resorption, most commonly in like the middle finger is where we see this. We can also do, x-rays of the skull, and you'll see that mottled skull appearance. And typically, we get an ultrasound for pre-op to identify which of the glands is causing this, whether it's all of them, whether it's one of them. And then we can do advanced imaging studies that are helpful to find any like substernal glands or any glands that might be somewhere else, parathyroid glands. So what's on our differential diagnosis? So we have, adenoma versus hyperplasia. We can have malignancy with these, so tumors that produce parathyroid hormone. If we remember back to some of our lecture, or the first lecture? Yeah, the thoracic cavity lecture as well, but some of our malignancies can produce this. And then we can also see it with thiazide diuretics, sarcoidosis, TB, renal failure, and then some other familial conditions as well. Typically with our thiazide diuretics, we might see a hypercalcemia, but it's typically not significant. So if they're on the thiazides, we typically draw calcium. If it's elevated, we get a PTH. And if it's normal, then typically that's just a side effect of the thiazide diuretic. The PTH is abnormal, and you still have to consider like a primary hyperthyroidism, parathyroidism in these patients. All right, hands off this one. All right, so there's our multiple endocrine neoplasias again. So MEN1 is associated with hyperparathyroidism, and it's also associated with those gastrinomas. So you have that recurrent peptic ulcer disease patient where you need to consider MEN1 in those. And we can also test for it if we have a suspicion too. Typically with these multiple endocrine neoplasia syndromes, they have a very high incidence of these conditions with them, so sometimes we'll do prophylactic operations if we've confirmed that they have this condition or syndrome. All right, so when do we do surgery? When do we remove it on these patients? So obviously if they have significant symptoms, so you got that recurrent like urolithiasis patient, any signs of osteoporosis, any like hypercalcemic crisis states. And then what we need to do for surgery is first we have to figure out which one of the glands is causing this. So we'll do a pre-op parathyroid hormone. We might have to do the ultrasound or any of those scans like the sestamibi scan to identify which gland it is. And then once we locate it, we typically remove it, send it to pathology, and then we monitor an intraoperative PTH as well to compare the values to make sure we remove the offending gland. And then if there are multiple glands are needed, then we may have to, if we remove all the glands, we may have to re-implant one of them. Sometimes we put in the forearm or sternocleidomastoid, but those are other procedures we can do for these patients. All right, so what sort of problems do we have afterwards? Well, as you can imagine, if we're taking out the parathyroid gland, we have to worry about hypocalcemia. Once again, we're operating on that area that's very vascular, so we have to worry about that hematoma and airway compromise, which, like I said before, we gotta, requires us to do an operative wound exploration and identify which vessel might be causing this. We also have our neurovascular injury, like the recurrent laryngeal nerve, which causes hoarseness. We have to worry about the thyroid too, because we might be removing some of the thyroid, which is important to check those functions. But our biggest concern is hypoparathyroidism afterwards, leading to hypocalcemia. Everybody remember the different signs, the chopstick sign, which is like, I always remember chopstick, cheek. Unless you tap on the cheek, and then they have the response in the picture there. And then we can also have Trousseau sign, which is more like a cramping type sign. And then they can have tetany. Some things we might see on the EKG are like prolonged QT. They can have hypotension, heart failure. Typically, we're going to provide oral calcium supplementation after the surgery. And then if they have severe symptoms, we might have to do IV calcium. And then once again, anytime we're cutting or making an incision in the body, we have to worry about infection. And then poor cosmesis. And then here's our responsibilities in primary care. So obviously we need to get that complete metabolic panel or comprehensive metabolic panel. We need, if the calcium's elevated, we need to get the serum parathyroid hormone, and then a chest x-ray looking for any primary tumors or metastases. And most of these are referred to endo or surgery. All right, you got a 45-year-old female underwent total thyroidectomy for follicular thyroid carcinoma, admitted for observation. Same night, she endorses tingling, fasciculation of her jaws. What complication are we concerned about? Yeah, hypoparathyroidism due to some sort of injury of those parathyroid glands or removal of them. All right, take a 10-minute break. Be back at 8:55. Moving on to the adrenal gland. So, the adrenal gland is obviously an important gland for homeostasis. So our hypothalamus tells the pituitary to release ACTH, and the ACTH stimulates the adrenal cortex, and that's what controls a complex array of hormones there. So we have our steroid hormones, our testosterone, aldosterone, our stress hormones, cortisol, and it creates a negative feedback loop with the hypothalamus to suppress ACTH. It also produces our catecholamines, typically in the medulla, which has a direct sympathetic response or stimulation. So it's an important organ, and all of this is important when we're looking at some sort of abnormal function of this. Typically, we'll talk about like pheochromocytoma and some of the other causes. The most common is going to be like our incidentalloma, which is basically a mass discovered incidentally on some sort of other scan that they get. So most of them are benign. They're typically hormonally inactive. You'll see a lot of times on CT scans of the abdomen and pelvis, they'll note these that they have some sort of incidentalloma on their adrenal gland. If they're symptomatic or hormone secreting tumors, then we look at more treatment than a possible removal, which we'll talk about. But you can also get metastases from the breast, lung, renal, melanoma, lymphoma. We get concerned when it's, depending on the size of it, so over 5 centimeters increase our suspicion that there can be malignancy, and then we also have to evaluate their adrenal function, so we worry about like Addisonian's crisis. And then we can have a derangement of multiple electrolytes if anything is abnormal. All right, so diseases of the adrenal gland. So what's on our differential? So really, we need to figure out what's causing this. Is this coming from the adrenal gland, or is this coming from the pituitary? So we need to look at their ACTH level. Typically, like, if we have any sort of adrenal cortical hyperplasia, we look at like primary adrenal disease. They may have an excess secretion of cortisol. And this typically manifests as Cushing's syndrome. If everybody remembers that Cushingoid patient with the striae, they got like the moon face, they got that buffalo hump. So sometimes they'll present with these symptoms, and we need to evaluate where that's coming from, whether it's coming from the pituitary versus the adrenal gland. So we'll typically run an ACTH for that. And if it's in the pituitary, we'll have the excess ACTH causing the stimulation, leading to Cushing's disease. We can also do like a dexamethasone suppression test on patients as well to assess their response, which dexamethasone is a steroid. And then if we suspect it's in the pituitary, we can do like pituitary surgeries to remove that lesion, or worst case, we can do an adrenalectomy, typically if the pituitary surgery fails. And then you can also have, like when we talk about small cell lung cancer, we can have ectopic ACTH production from one of those tumors. So it's always something we need to evaluate, especially in the right patient. All right, so pheochromocytoma. So this is tumor of the adrenal medulla, and it secretes epinephrine. So this is that classic triad: headaches, palpitations, diaphoresis, typically paroxysmal. So it's just at sporadic times throughout the day they're going to have a release of these catecholamines causing these symptoms. They can present with a stroke or MI with this. And then 50% of these patients, we find MEN2 being associated with it, especially with neurofibromatosis, as you can see in the picture there. And so what do we do for this? We need to do our urine and serum metanephrines, and then we need to do imaging to locate the tumor. We want to control their hypertension to prevent a hypertensive crisis. So this is important that we control them first with an alpha blockade, because if we have unopposed if we have our unopposed like beta blocker, we worry about alpha vasoconstrictive activity that can lead to a severe crisis. So you're going to have like vasoconstrictive activity leading to severe hypertension. So we don't want to start with a beta blockade like we do in other, like we might do in other cases of patients, like with our hyperthyroidism or thyroid storm. So in a patient with a pheochromocytoma, we have to start with an alpha blockade, followed by the beta blockade. So, where's my medications? Hold on. All right, sorry, it's on the other slide. All right, so if we have a tumor that's secreting epinephrine, we run our serum metanephrines. Obviously, we control their hypertension. We'll give them an alpha blockade, usually like 1 to 3 weeks before any sort of operation is planned in the pre-op phase. And then we want to confirm before we do the scan. So this can be done with CT and MRI typically. So we take that 24-hour urinary, our catecholamines and metanephrines. And then once we diagnose it, we have to localize where we need to perform the surgery. So CT and MRI are a great test for that. We might have to do like a PET scan, looking for any sort of metastasis in these patients. And then if it's hormonally active, that's when we do the adrenalectomy. Typically, we do a laparoscopic procedure nowadays. Well, we really only do an open one if we're worried about metastases. And then we do have to worry about intraoperatively complications with this procedure. So we can have our hypotension, a refractory hypotension post-op. And then, so it's important that we have great blood pressure control for this. We may have to give pressors during the surgery or IV fluids. And if it's hormonally inactive, then we typically don't do anything with it if it's under 5 centimeters, other than repeat CT scans every 3 to 6 months just to monitor for any growth. But typically we leave the hormonally inactive ones alone unless they're causing symptoms. All right, so what do we do in the primary care setting? What is your guys' job here? So, you obviously want to get the CBC, you want to get a comprehensive metabolic panel, we want to check the parathyroid hormone. We also want to, we can, if it's indicated, do a decadron suppression test, and we can measure serum VMA, which is just an acid that we can run with the metanephrines. And we want to look at urine catecholamines. We usually get a chest x-ray. And then you could consider CT, MRI, and a referral for these patients. Typically, I would hold off on scans and talk with the internal medicine or endo doc or surgeon first before you're ordering any of these further tests. And they may want to order them themselves just to get depending on what you have at your facility and what tests you can run. All right, I know we've covered a lot today. What questions you guys have? Yeah.
Sir, for the FEOs, even if they're not, or I guess any kind of adrenal mass, even if it's not hormonally active, can it cause like suppression or effects on other hormones? Like if it is big enough, I guess.
It typically doesn't, no. Yeah. It'll start to cause like a mass effect at a certain point, which is why we tend to remove them. What else? All right, I'll hang around for any questions.